Hi there, I'm Jim Montgomery, and I want to thank you for joining us today. Like Dr. Kolker, I share a passion for computer simulation. In fact, I first observed my first animated simulation back in graduate school, and I guess you can say I've been hooked ever since. So it's a pleasure to share today the hospital patient flow optimization model that we have developed at the Carilion Clinic. Basically, it is a macro level simulation in which we model the simultaneous patient flow among 26 different wards on our hospital. So just to start out, so you can relate your health system to ours, a little bit about Carilion Clinic. We're headquartered in Roanoke, Virginia. It's a city in the southwestern mountainous part of our state. We serve approximately 1 million people in 23 counties. We've got the Tertiary Care Center located in Roanoke, and that's the building there you see the photograph of. We've got 6 acute care community hospitals that are in the surrounding areas. We've got 1,215 licensed beds, approximately 11,000 employees, and an average daily census of about 630. That's the system overall. And we operate a medical school that's in partnership with Virginia Tech. And our continuing medical education includes 11 residency programs and 10 fellowships. So this is the agenda I'd like to work from today. I'm going to talk about how this has added value to Carilion. I'm going to talk about that green-eyed monster variation and how it got in our way, but how we used computer simulation to try to work around that. We'll talk about how simulation allowed us to construct scenarios in order to test proposed operational changes. This is after I get to demonstrate the model for you. I'll put it on full animation mode, and we'll take a look at that. And then we're going to, I'll show you how the results of those scenarios that we built help to drive the solutions. And we'll talk about lessons learned and then go into questions and answers. So, quick background. Really, we thought it would be of value to partner with ProModel to build this type of discrete event computer simulation. So, the problem that we faced, and this would happen several times a year, we would go into a situation called peak census. And essentially, peak census is not enough beds to accommodate all the demand for admissions. So, I guess you could say too many admissions facing too few beds. So historically, the solution to this problem would be to go into crisis mode, have crisis management committee meetings, micromanage the discharges and transfers until eventually the situation resolves itself. So we thought it would be of value somehow to use a predictive analytics to estimate maybe the impact of some of the various operational proposals that were on the table that might improve patient flow. And we found this was a good tool to help in that regard. So bottom line, the value we found was in the form of cost, time, and capacity. In regards to cost, we did find this was an environment in which we could experiment without the cost of actually opening or expanding a unit. And as Dr. Kolker pointed out, we can experiment with the system behavior without experimenting with the actual system. So, for example, opening up a new PCU would be a major commitment of resources, such as staff and equipment, but we can do that virtually, and we can do it at no cost. The other value point, time, as Dr. Kolker said, the model has the value of compressing time. Well, imagine you're in a committee meeting in which the patient flow is being discussed. In fact, this committee is charged with finding solutions to patient flow, and somebody has a good idea. Well, to implement any idea in a hospital, it takes a lot of time and resources, but what if somebody in that committee meeting is sitting there with his laptop computer and he's got this simulation model loaded, and he can run through various experiments that are proposed by various committee members, and before the discharge of that committee, some estimates of some results that would take place. So if those initiatives were to be implemented, so that would speed up the time greatly by which decisions could be made. Now, well, that's something that we have the capability of doing. So instead of that long implementation process in which you might want to test say a new discharge procedure. What if on a particular ward you think you can discharge patients 12 hours faster than before, so you have a 12-hour reduction in length of stay. So how might that impact the census on that unit, or maybe the census in several units? So that's the type of thing that the simulation could tell us. So, and then the next value point is in terms of capacity. So just knowing that the decision to open up PCU bed space would reduce PCU unit census by an estimated amount, well, that's valuable information. So likewise, maybe I would like to put the hospital in peak census and test capacity solutions. So I can do that virtually. So, and additionally, what if I want to test the impact of adding a new procedures or new surgeons on capacity? Well, the model lets me do that also. So now addressing some of the problems with traditional methods of analysis. So it's hard to make decisions involving complex systems such as hospital throughput because of the variation in the system. And if you tinker with one part of the system, that can have far-reaching effects on other parts of the system. So say, well, we've got variation, for example, in volumes of arrivals, between months of the year. Timing of arrivals is different. Arrivals change from day of the week. Admissions are different on a Monday versus a Saturday. And then patients flow at different times of the day. We have peak periods by which admissions would come through the hospital as opposed to other hours of the day. Know that service lines of the specialty of the admitting physician, those particular type of patients present unique attributes. A cardiology patient is different from a orthopedist patient. And of course, the acuity level of the patient at the time of the admission, that's going to vary. You can have a medical surgical patient, a progressive care unit patient, or somebody who needs an intensive care unit. Bed capacity among nursing units is always changing. Our transfer center, they're the ones that they kind of act like a traffic cop. They make patient room assignments or ward assignments. They try to use an algorithm that's based on the physician preference, also take into account the acuity level of the patients, the service line of the patients. Sometimes they also use some cross-leveling on different wards as well. So a lot of variation in that aspect. Patient length of stay varies. It varies by acuity level, certainly by service line, certainly by the number of times they may have hopped between units. Speaking of hopping between units, variation point number 8, patients move between units. They could go up in acuity. They could go down in acuity. They could go laterally to a unit of similar acuity also. So, and then compound this variation problem by the fact that this is happening to approximately 340 patients all simultaneously. So one quickly comes to the conclusion that this problem cannot be solved using standard spreadsheet analysis. So right now I'd like to take you on a little demonstration. I'm going to run the model for you. So this model is based on 2 years worth of data, and the way we solve this variation problem is by using probability distributions. We use lots of probability distributions in building this model. And let's see, this model is a partnership between Carilion Clinic and ProModel Corporation. Carilion Clinic wanting to have a census management decision support tool that we can put into place. ProModel wanting to expand upon an existing product that they had for hospital patient flow, but using some of the complexities of what our hospital would offer them. So right here you have this control. I can slow down this animation. I can speed up the model as it runs. Over here I have I can see the replication number. This is 1 of 40. I typically run about 40 simulations. That would, in this case, that replications. In this case, that replicates 40 years of activity. I figure that most of the variation can be accounted for in 40 years of hospital service. Over here you can see the week. This is week 21 of the simulation. Now we will run up to, this model runs 64 weeks. And now I don't start collecting data until week 12 because I want the hospital flow model to be at a steady state before I start collecting any data. Here you see this is the day of the week. We're flying through, and then the time of the day that we're also moving quite rapidly through right now. Over here I've got a series of variable counters. I could put anything here that I want. You can see that percent of beds filled is running about 80%. Hospital census somewhere between 300 to 340. Now patients flow into the model at a rate of around about 520 admissions per week, and they'll flow in, and the probability distribution will account for the time, the hour of day by which they come. Some heavier hours than others. We'll find that some of the patients enter the system through the emergency department, about 40% of them. Others will come in straight admission to a unit. Probability distribution also governs the service line by which patients enter the model. They could be a hospitalist patient. They could be a cardiothoracic surgery patient. They'll come in, spend a quick time in a queue, and then be assigned to one of these beds. Now, probability distribution also governs the acuity level. They could be a medical surgical unit patient, a PCU patient, or an ICU patient. Now, when they get to the hospital or get into the model, they'll flow into one of 26 different units. And we govern the way they get to the unit. We try to mimic the logic of the actual transfer center, so that taken into account are the acuity level, the service line, and let's see, that's what governs getting them to the unit. Now, once they get to the actual bed, now you have the capacity of each unit can be changed according to a different scenario that I might want to run. So capacity mimics reality. In the get there, you see that some of the standard patient is in the green hospital gown. Some of these patients are showing up in red, and those are our observation patients. They don't take as much time, but we still have to account for them as they are taking up a bed. And you can see room cleanup. You can see a little sign marked room cleanup, and that means that a bed is occupied while housekeeping comes in, cleans the room. So that all helps to mimic reality. Takes up bed space. So you can see this particular counter is telling us what the census is on 8 West at the moment. This gauge is going to tell us what the capacity is of beds filled. You can see that we're running somewhere between 80 and 90% occupancy level on this particular unit. Now, something else that is accounted for with probability distributions is the patient flow between units. You know, you can go up in acuity, you could go down in acuity, or you could go between units, and that's accounted for with probability distributions also. One more thing, when the patient gets to a unit, they stay a particular length of stay based on one of 109 different probability distributions governed by acuity level and service line. So, hey, this looks really cool, and it also serves as a catalyst for discussion when you run the animation in a committee meeting, but the true value in a discrete event computer simulation model is in the thousands of statistics. In this case, approximately 45,000 statistics, 45,000 patients that flow through the model in a given year times 40 years. So as Dr. Kolker pointed out, that all the system's statistics for entities and their activities are gathered up, compiled, and ready for viewing at the simulation end. So moving on. So I'm going to take a look at how we actually have applied this. And one of the things that we questioned was if we close up some swing beds in a couple PCU units and then open up a PCU that's got 8-bed capacity, what would be the impact? If we open up an additional unit with 9 PCU beds, what would be the impact there? And how about if we set aside a PCU ward for observation patients only? So these were some of the questions that we were kicking around and wanted answers to, and yes, you could say these would be the the Y variables, the output on the next 4 items. What would be the census on the units affected? What would be the % of beds filled on the units affected? Or how about overall hospital census? Can you tell us that? And can you tell us the % of hospital beds filled? So to answer these questions, the computer modeler comes up with scenarios. In this case, we've got 5 scenarios that we're working with. Scenario 1 is just the base case, and this was used to validate the model. We used 2 years. This is the 2-year 2010-2011 data. We built the model with the base case, but then a few things changed in the course of time after we built the model, so we upgraded it, and that's the new scenario 2. Some more admissions, a few changes in units. So scenario 2 is the new base case, and now we compare everything to that. Scenario 3, this is where we open up the 7 Mountain PCU 2. That's got 8 beds, and we close down the 5 swing beds on each of 7 South and 8 South. And then scenario 4, we're going to expand capacity, opening up 9 beds on 7 West. And then scenario 5, what if we establish 7 East PCU exclusively as an observation unit? So, as we said before, the model is good about spitting out results. So let's look at this first graph. This is showing us % utilization. On my y-axis, we've got 5 different PCU nursing units. On my x-axis, we're going to look at % utilization. So you can see scenario 2 is the status quo. Scenario 3, the green bar, is going to be where we open this unit and close some other beds down. Scenario 4, that's the yellow bar. That's where we expand capacity by opening up a new ward. And the red bar, that's the last scenario where we're going to establish 7 East as an observation exclusive unit. So down you can see that we achieved the results that we were looking for. That was to reduce % utilization. You can see that that was coming along good, and on 7 East, see, we've got a markable reduction in % utilization. And you can see that in these first 3 scenarios, that's pretty much the way it's going. We've got reduction in % utilization all the way across the board, pretty much. However, when we throw in scenario number 5, we see that, well, maybe that wasn't such a good idea, because if you do that, you reduce % utilization on this exclusively observation unit down to 25% from originally 92%. And you can see what happens on the other units as they scramble to make up for the patient load that are now were being evicted on 7 East because they weren't observation patients. Now % utilization grows on each of these other units. And you can pretty much see the same trend when we look at 5 other PCUs that are shown in the graph. You can see how this final scenario ups the percent utilization, okay, where there was a trend downward before. So just some of the things that this simulation allows one to look at. If you want to look at data perhaps a different way, you could look at just the average daily census numbers and excess capacity numbers. These graphs are marked with the y-axis showing census, average daily census. The x-axis shows your different scenarios, and here the light blue bar represents average daily census. The dark blue bar represents excess capacity. So this allows one to see what excess capacity might look like across the scenarios on different units. You see 12 West, moving from 4.33 down to 6.66, or increased excess capacity here. So another way to look at that, 7 West was was back in scenario 4. 7 West was a unit that we stood up. You can see they had 0 before and then jumped to 6.65 census. These are the units that had the swing beds that we closed down. You can see how they dropped in excess capacity across the various scenarios, and you can see how basically all these wards are affected across the scenarios. Say we want to roll up all PCU units. You can see how they might be impacted. This is average daily census numbers, excess capacity numbers. Over here on this side, you've got the same PCU units, but now you're looking at percent filled. Hospital overall, if we want to look at those numbers, we can see how those numbers vary across at least scenarios 2, 3, and 4. Just one more way to look at the data. This is on some separate scenarios, not the one that I mentioned beforehand, but if I put those graphs in 3D, I can also, it tells another story of percent beds filled across different scenarios. This is interesting because you can also look at medical surgical units. You may be dealing with PCUs, but you can also look at the impact. There is definitely impact on medical surgical units also when you start tinkering with the PCUs. And in our case, this is because some of those PCUs doubled as med-surg units. So of course, it's something that the model allows one to look at. Now, here's an interesting results slide. Now, this demonstrates the results of a sample scenario in which the built-in feature of revenue generator is experimented with. Now, we wanted to look at how estimated gross charges might be affected. So to build this function, we used the 2-year database. We studied charges per APR DRG. Then we used probability distributions. See, lots of probability distributions to assign the APR DRG to each patient based on service line, and thus capture a charge for each patient. So what we're trying to find out here is that if any change in an X variable, just any given input variable, produces a statistically significant change in the Y variable, in this case revenue, then this model should point this out to us. So just one more neat feature that's built into the model. And then another way to look at data, we have another built-in feature that shows what percent of physicians' first choice unit assignments were assigned. So you have a situation where most cardiologists prefer to have particular units, their patients assigned on particular units, and it looks so historically 80% of cardiology patients were assigned to their first choice for bed. However, scenario number 2 is put into effect, and then that level of getting the patients to the right place drops by 40%. So what happens there is just something to experiment with if you find that valuable. We find it pretty fascinating. So some of our lessons learned. Well, first of all, we shortened the process by partnering with ProModel. think I like to tell people otherwise I would still probably be writing code for this simulation. Essentially, we were a beta test site for development of this product. And I think now that the most valuable capabilities are embedded in the model, and the model is validated, going forward, a site really wouldn't need a modeling guru to have success with this model. So I think the next bullet point talks about the need for building rapid flexibility into the model. I think that's an important thing because as you start going down this road, people in leadership positions start asking, well, can you do this or can you do this? And so it's good to have as much flexibility as you can built in from the start. And I think we've been through several of those scenarios now with trying to meet the needs of different decision makers. I think it's also important that flexibility allows one to get answers within maybe minutes or hours, at the most days, as opposed to an analysis that may take weeks or months to get feedback. So I think also an important point is budgeting additional time for verification and validation. I think this is key. That's how you know you have a good model, when it's validated. And then making sure that your data sets include all of the patients occupying beds in your research locations. Example, in our case, the observation patients, well, the model was already built when we realized that the data we used did not include any observation patients, so that was an add-on. So our plans for future ongoing use of this tool, well, we've got a lot of flexibility built in so that as new what-ifs arise, we can test those rapidly. I think one thing is we certainly look forward to exploring the impact of length of stay reductions caused by individual nursing unit discharge initiatives. So, at this point, that concludes my portion of this presentation.
Well, thank you, Jim, and thank you, Dr. Kolker, for your insightful presentations. That was wonderful. We will now move into the Q&A part of our program. At this point, I would like to invite our audience to continue sending in their questions or comments in the same question panel. I've already received some questions, and I'll start with those. My first question to our panelists is, you mentioned that the validation of the model. Could you explain a little more about the process of the validation of the model? Also, what role do the key stakeholders of this tool play in validation?
Okay, yes, that's a good question, and I just happen to have some validation, some backup slides whereby we can take a look at some of that. Yeah. I agree. You need to question, whoever sent that in, you need to question the data, and you need to question the validation process. Because as W. Edwards Deming said, in God we trust, all others bring data. So that's appropriate in this case. You should never trust the results of the model that wasn't validated. And there's two types of validation steps that I use. I use face validation, and I use a comparison of means. And I guess to answer your question there, how would key stakeholders play a role? Well, this model was demonstrated in front of key stakeholders, both one-on-one and in the committee meeting. And both times we're asking them, well, does this model resemble reality, is the first question. And then the second question is, well, how can we make the model better? So, those two questions, and we incorporate what is said after we run the model in animation mode, and we incorporate the feedback, and that goes back into the building of the model. Now, the second type of validation has to do with a comparison of means, and this is where we take data sets from the empirical data, and that's the the 2-year data set, the real data on admissions that you use to build the model. You take a means there of something like length of stay, and you compare that to a model-generated data set, also of say length of stay, and you compare the means of those two. And you need to have close means there in order to ensure the model is valid. So I used 2 different sets of means for this model. The first mean was length of stay, and we compared length of stay along the macro level, hospital-wide, but then we also got out to the individual service lines and compared those lengths of stay. And then average daily census was another data set that I used to validate the model. We used not only the hospital-wide, but also the units, the individual units, and we looked at the comparison of means of how the empirical data tracked against the model-generated data. So now, overall, hospital-wide length of stay was at we're 2%, within 2%. So yeah, that's pretty good. And then the average length of stay hospital-wide was less than 1%. It was 0.7%. That's how the 2 means compared. But we just didn't want to stop at the hospital-wide numbers. We wanted to look, and this is what I wanted to show you now. That here you can see this chart. This shows length of stay, and you can see on the left the different service lines of the model, and you can see that the percent change. So each service line, we looked at length of stay, and so we vary anywhere from 0.1% up to 7.3%. So we think that's pretty good. And this is how we looked at the average daily census. You can see that on these different units, the little triangle represents the model-generated data, and the bar we're trying to reach. We're trying to get within 2 beds, plus or minus 2 beds, and so we're trying to get within that bar all the way through. And we found that 23 out of the 24 units here are within the 2 plus or minus spread. So that's the validation. Maybe more than you wanted to hear, but that's validation. If you don't have a valid model, you don't have a model. So thank you very much.
Thank you, Jim. Our next question is, how frequently will you use it going forward once your main initial questions are answered? Do you see it used monthly or quarterly?
Okay. Well, monthly or quarterly? The answer would be hopefully yes and yes. Sure, would like to see it monthly and quarterly. This model is designed to accommodate ongoing improvement, and our system is headed towards ongoing improvement. We're taking continuous calculated steps towards process improvement. So yeah, this is the type of thing, and we're still sort of in the infant stage as far as really exploring the capabilities of the model. So we used it, but typically every time our committee meets, there's another mission to go out and seek and find out a new answer. So we're at the kind of the infant, the exciting stage here. That's how I would answer that question.
Yes. We have our next question. It's clear that this is an effective strategic planning tool. Do you foresee using this tool in a more tactical manner in the future?
Well, I think the great advantage of this particular model design is the flexibility that's built into the model for creating scenarios or the what-if analysis. So I think just like you can look at the kind of the macro level or the strategic level, you can also look at the micro or the tactical level. So we can design experiments to look at how the X variables of specific nursing units or changes to specific product lines might affect localized Y variables. I think in addition to that, we we have plans. We've talked about building new modules into this model so that so we wanted to look more closely at the ED and have the ED interact with this model. Same thing with operating room. What if we were to build a new module so that we had operating room patients flowing in to the model and get more down into the detail on those particular systems that are generating patients into the model. So yeah, lots of opportunity here. Thanks.
Thank you, Jim, for that excellent Q&A session. Well, that's all the time we have for today's Q&A, and we had a lot of questions coming in from the audience. ProModel will follow up after the webinar with anyone who submitted questions that were not answered. Please also feel free to contact any of our speakers at the emails shown on your screen. Thank you everyone for participating in today's conference. You'll be receiving a follow-up email from Xtalks with access to the recorded archive for this event. Please join us in thanking our speakers for today's conference. Mr. Jim Kane, Director of ProModel Healthcare Solutions, Dr. Alexander Kolker, Outcome Operations Analysis Project Manager from Children's Hospital and Health System, Milwaukee, Wisconsin, and lastly, Mr. Jim Montgomery from Carilion Clinic. We hope you found this conference informative. A survey window will pop up on your screens. Your participation is greatly appreciated, as it will help us in developing our future webinars. Thank you and have a wonderful day. Goodbye and good day.